In a report from yesterday, genomic sequencing is being used to settle a centuries-old rumor about whether a Medici duke poisoned his brother. It's a precise use of technology to pin down a historical truth once lost to gossip. Yet, writing last week for Stat News, Ben Lopman describes a different reality for modern science. What's striking is how these two perspectives sit together. While DNA analysis gains authority over the past, the standard methods used to monitor public health today are being met with a manufactured skepticism. It's worth pausing on this friction, a culture reaching for absolute certainty in the bones of the dead, while casting doubt on the data meant to keep the living safe. Writing for Stat News last week, Ben Lopman examines a sudden friction inside the CDC over how the agency measures whether vaccines actually work. Leadership is questioning long-standing epidemiological tools, framing established science as a matter of open debate. What's worth listening for is how he describes the test-negative design. This study method is the backbone of modern vaccine tracking, yet it's now being treated as a target for skepticism rather than a standard tool.
What happens if public health agencies stopped trusting their own tools, scientists, and surveillance networks for measuring whether vaccines work? We end up less able to monitor the performance of COVID-19, flu, RSV vaccines, and whatever comes next. That's the real story behind the recent Public Health Ground Rounds, CDC's flagship seminar series on the topic of measuring vaccine effectiveness. While this may seem like an esoteric topic, it sheds light on the ongoing disruption within the agency over vaccine policy. CDC leadership has already blocked publication of its own staff's research on COVID vaccine effectiveness, citing methodological concerns. And just this week, Health and Human Services posted a new charter for the Advisory Committee on Immunization Practices, the panel that advises CDC on vaccine recommendations, that diminishes its role in evaluating vaccines and instead directs it to assess alternatives to vaccination. The methods used to measure whether vaccines work and the way they were discussed during the recent seminar are not a side issue. They are squarely in the crosshairs. In his opening remarks, Jay Bhattacharya, who was leading the agency, though not officially acting director, framed the series as a reflection of CDC's renewed commitment to the principles driving scientific progress: excellence, collaboration, transparency, intellectual honesty, and willingness to engage in thoughtful debate on complex issues. Great! The specific topic was how to measure the degree to which vaccines protect people in the real world, so-called vaccine effectiveness studies. In fact, the discussion went deeper than that, hinging on a debate about a specific study design.
The panel included 3 scientists with deep expertise in vaccine effectiveness methodology: Carrie Reed, chief of CDC's Influenza Epidemiology and Prevention Branch; Emily Martin, professor at the University of Michigan; and Natalie Dean, associate professor at Emory University's Rollins School of Public Health, as well as a representative from HHS Leadership, Martin Koldorf, chief science officer for the Office of the Assistant Secretary for Planning and Evaluation. Reed and Martin presented, in depth, the principles of real-world vaccine studies and the methods underlying them. They laid out the fundamentals of the study designs, the reasons we use them, the real-world questions they have answered, the policy decisions they have informed, and, critically, their limitations, as well as the decades of work that have gone into examining how significant those limitations are and what can be done to address them. While there are many approaches to estimating vaccine effectiveness, the test-negative design, or TND, is the mainstay. It's a form of a case control study, where you compare people who had a disease, cases, to those who didn't, controls. The innovation of the TND is that cases and controls are identified based on whether they test positive or negative for a particular vaccine-preventable pathogen. For example, if you're hospitalized with a severe respiratory infection and test positive for flu, you're a case. If you test negative, you're a control. Then you look at whether those people were vaccinated. If the vaccine is working, cases will be less likely to have been vaccinated than controls. It's an elegant solution to a real-world problem. It's fast, inexpensive, and widely used.
Of course, it's not perfect, which is precisely why the scientific community has spent years working to validate and improve it. That's how applied science works. Koldorf claimed on the grand rounds to have identified the fatal flaw in test-negative designs. One of his stated fatal flaws was that you can't use this approach when cases and controls have different diseases. You shouldn't use it to compare risk factors for pancreatic versus lung cancer, for example. To which the response of the other panelists, and I'm imagining my entire field watching the webcast, was essentially, of course, and that's why we don't. The TND relies on people seeking care for the same illness, like symptoms of a respiratory infection. They don't seek care for a specific pathogen. But as Dean pointed out, vaccines prevent specific pathogens. COVID vaccines prevent SARS-CoV-2, but not RSV or flu, and that's precisely why the design works. So why does any of this matter? It matters on two levels. First, practically. If the TND is discredited or sidelined, we lose one of our primary tools for monitoring vaccine performance in real time. This is the kind of ongoing surveillance analysis that tells us whether this season's flu shot is working, or if a new vaccine, like for RSV, is performing as expected. Second, politically. Bhattacharya has already blocked publication of a CDC study on COVID vaccines, citing concerns regarding the methodological approach to estimating vaccine effectiveness. Notably, the paper was ultimately published in a peer-reviewed journal. Others have written extensively about the inconsistency and lack of logic in that decision, so I won't here. More broadly, Koldorf, Bhattacharya, and other appointees in Robert F.
Kennedy Jr.'s HHS have raised persistent doubts about COVID vaccines and about vaccine science more generally. What happened at the grand rounds appeared to be an attempt to manufacture a scientific debate where, in reality, there isn't one. The TND works quite well. Some of the world's foremost experts in TND and vaccine evaluation are at the CDC. They have innovated impressively with the constraints and resources and data available to them, and they constantly work to validate and improve their methods. Any open-minded observer would have come away from the discussion reassured that these scientists and the broader network of investigators who seek to answer questions about vaccine performance in the real world are rigorous, creative, and methodical. Bhattacharya's closing remarks included the platitudes, "We owe each other this kind of discussion," and "We owe the public the very best regarding the truth." However, a more pointed truth emerged from the recent discussion. We have robust tools for evaluating vaccines in the real world, and a community of committed scientists who dispassionately do the work. They don't claim their methods are perfect. They've spent careers proving they aren't, and improving them anyway, and they will continue to do so. The question now is whether the institutions that depend on that work will trust it. Ben Lopman is professor of epidemiology and global health at Emory University's Rollins School of Public Health.
Lopman leaves the listener with a picture of an agency at odds with its own data. It isn't just a policy disagreement. It's a fundamental challenge to the test-negative design and the very metrics used to track if a vaccine is keeping people out of the hospital. There's a sense that even with mountains of data, scientific certainty is being treated as a moving target, something that can be debated out of existence by shifting the goalposts of what counts as evidence. Then comes the study from the Medici chapels in Florence. It's a sharp contrast. While public health officials are questioning the validity of modern surveillance, researchers at Yale and the University of Pisa are looking at 500-year-old rib bones to settle a cold case. The Smithsonian piece relies on the authority of genomic sequencing to debunk centuries of gossip about arsenic and betrayal. It assumes that science can and should have the final word on what killed Francesco I de' Medici. Read alongside Lopman, the observation is hard to ignore. In one context, the tools of proof are being questioned to make space for alternatives. In the other, those same tools are being used to reclaim the truth from the past. It makes one wonder why it feels easier to trust the science of a 16th century fever than the science of last year's flu season.
Did this Duke poison his brother? A new DNA analysis may solve the centuries-old Medici mystery. Researchers found evidence of malaria in Francesco I de' Medici's bones, leading them to argue with scientific certainty that it was disease, not arsenic, that led to his death in 1587. When Francesco I de' Medici, the second Grand Duke of Tuscany, died within a day of his wife in October 1587, some observers suspected foul play. Who stood to benefit from the couple's deaths? Ferdinando, Francesco's estranged younger brother, was next in line for the throne, making him the most likely culprit. Rumors speculated that Ferdinando had poisoned his unsuspecting brother and sister-in-law during a hunting trip. The truth, as it turns out, is far more mundane. A new study published in the journal iScience debunks this dramatic narrative, attributing Francesco's death to malaria. The genetic analysis suggests that the disease, which ran rampant in central Italy until its eradication in the region centuries later, also killed a third Medici brother, Giovanni. At the time, both were diagnosed with symptoms, such as intermittent fevers, consistent with malaria, says co-author Valentina Giuffra, a historian at the University of Pisa, in a statement. This genetic analysis confirms the historical accounts, as well as prior research. Need to know: the Medici family. The House of Medici ruled over Florence and later Tuscany between 1434 and 1737. Known for their art patronage, the family made their money chiefly through banking. Famous members of the dynasty included Lorenzo the Magnificent, Cosimo I, and Catherine de' Medici. For the study, researchers extracted DNA from the rib bones of Francesco and Giovanni, who are interred alongside other members of the dynasty at the Medici chapels in Florence. The location of the Grand Duchess's grave is unknown, so her remains weren't available for analysis. The team identified Plasmodium falciparum, a parasite responsible for the deadliest strain of human malaria, in the bones of both brothers. Francesco's remains also bore traces of a second parasitic species called P. malariae. The findings demonstrate how we can use advanced ancient DNA laboratory methods to map the history of this deadly pathogen, senior author Serena Tucci, an anthropologist at Yale University, says in the statement. Giovanni was infected with a previously uncharacterized strain of P. falciparum that included 2 unique genetic mutations. This strain may have evolved from a similar one that spread across Europe at the time, but further research is needed to confirm that hypothesis. 25 years before Francesco's death, in 1562, his mother, Eleonora of Toledo, and 2 of his brothers, 19-year-old Giovanni and 15-year-old Garcia, died unexpectedly. Although the Medici family maintained that all 3 had contracted malaria while traveling to Pisa, rumors of violence persisted, with gossip suggesting that Garcia had murdered Giovanni after a falling out, leading their father, Cosimo I, to kill him in retribution. A 2010 study, co-written by Giuffra, cast doubt on this version of events, confirming the clinical diagnosis of the court physicians using modern methods, specifically immunological investigations. The paper's authors pointed out that the Medici family's villas and hunting grounds were located in coastal or marshy areas that held a high risk of exposure to mosquito-borne diseases like malaria. Francesco caught malaria under similar circumstances, falling violently ill while hunting in Tuscany. According to a 19th century account of the Duke's death, doctors treated Francesco's high fever, vomiting, and convulsions with bloodletting. He refused other treatments, including enemas, and, quote, ignored the precepts of physicians, drank and gargled with water and wine cooled with snow, and even cooled his syrups with snow. The Duke died 11 days later, with his second wife, Bianca Capello, following him to the grave the next day. Ferdinando's presence at his brother's deathbed immediately prompted whispers of wrongdoing. It has been suggested that death rode from Rome in company with Cardinal Ferdinando, who had everything to gain by the event and who at once succeeded to the duchy, a 20th century chronicler wrote. Ferdinando's well-known distaste for Bianca, who'd been Francesco's mistress before the death of his first wife, further fueled the rumors. The cardinal had, quote, resented Bianca's meddling in court affairs and accused his brother of behaving in a manner unbecoming his ducal role, the 2010 study noted. But the brothers apparently reconciled just 2 weeks before Francesco's death. The new genetic analysis solves the mystery of the Grand Duke's demise, allowing researchers to pin the blame, quote, with scientific certainty on malaria rather than poison, Giuffra says. As first author Alexander Ochoa, a research scientist at Yale, explains in the statement, the study of ancient DNA offers us an opportunity not only to diagnose malaria in the remains of individuals from the past, but it also offers us a window for understanding the evolution of malaria species, Plasmodium falciparum in this case, which can help scientists better understand how the pathogen adapts over time.
Sequencing a strand of hair to settle a centuries-old rumor about a king's illness offers a clean, quiet resolution. The math gets noisier, however, when those same tools measure the air in a crowded room or the efficacy of a new shot. There's a strange comfort in letting science rewrite history, provided it stays safely in the past. What lingers is the choice to trust a microscope only when the patient is already a ghost. Why does the same evidence feel like an answer when it's history, but like an argument when it's life?